So this video is about statistic again, but the video focus will be on we first want to say about the type of the study design. So let's begin with the chronological features of each study. So basically, the evidence-based medicine is based initially on the expert opinion and also expert's opinion and some lab tests. But the problem is that sometimes the lab test and also expert opinion can be different. Expert's opinion especially is exposed to a lot of bias, and also the expert's bias and also the expert experience itself. So sometimes you might have a lot of opinions from the experts. So that is why it's the lowest in the hierarchy. But from here, people start to report on the making a report. So we have a case report and a lot of or series of case report will become a case series, but it's still exposed to a lot of bias and also confounding factors. So later people start to do a case control or cross-sectional studies, and afterwards cohort study comes into play. We'll go and explain more further on this. And all of this is actually an observational studies. So we don't do any interventions. We just want to we look at the disease and also the exposure that may cause or contribute to the disease. Later on, after that, we start to intervene, so intervention. So an intervention study, you have the RCTs or randomized control trial. It can be blinded or non-blinded. Of course, a blinded RCTs, randomized control trial, is better than the non-blinded because of the less of the bias. And after we have multiple RCTs, sometimes the outcome might be different. So people start to develop meta-analysis and also systematic review, with or without meta-analysis, systematic review. And from here, the researcher, the doctors, the scientists will develop a guideline, especially in clinical world where we want to have a evidence-based medicine, and we start to put up a guidelines. So guideline might be different. RCOG have different guideline, AOG different guideline, Malaysia guidelines also different depending on the locations and the logistic issues of each. So now what I want to talk about today is actually what is cohort and also case control, because the other parts of it is quite clear. So let's go to this table. So what we have here, for example, this is a researcher. So basically, case control is when you don't know about the disease. You know about the disease, but you don't know about the exposure. So this is your clinical questions. You want to see, let's take this exposure. For example, you have cervical CA, you have a patient with CA, and you have a patient without CA. So you have a patient with disease and without disease. So this is CA, this is not CA. So you know about the disease already, and this is you. You are the researcher. So you want to see in a patient with cervical CA, how many of them is actually exposed to smoking and non-smoking. So from here, it's actually a case control, where you know the disease, you have the case, you have the control, and you just want to see the exposure. But if, let's say, you already know about the exposure, so you have a patient here who is smoking. This is a patient who smokes, and this is a patient who is not smoked. So you know about the exposure here. And you want to know about the disease. So basically, you want to know how many of those who smokes actually developed the disease. But this is you. So from here, you actually want to see all the patient. For example, you have 10 patients who actually 5 of them is smoker and 5 of them is not smoker. So you want to see whether this among these 10, 5 patient who smokes and 5, how many of them actually have the disease. So this is disease. If you do this kind of studies, then you are doing a cohort. But this is a retrospective cohort. Okay. And now, if you know about the exposure, for example, you know you have 2 kind of patient who smokes and who does not smoke. And then you come in between here. So this is you. And none of them develop disease yet. So you want to see in, for example, 13-year-old girl who smokes, how many of them will develop this disease. So you want to see future disease. If you conduct this kind of study, then it is a cohort, but it's a prospective cohort. So sometimes you have a previous data. For example, you know about the patient who's actually exposed to smokes, and then you just check again their notes whether they develop the disease or no, and you have this exposed or non-exposed group. But in prospective cohort, you look at how many of them smokes and how many of them will develop disease later. And this is the highest quality of observational studies. But the high dropout rate is very high and is very expensive. Okay, so now let's talk about if you have a forest plot, sometimes you might see here 1 and sometimes they report as OR or RR, right? This is non-significant. Sometimes you can see here it's a square. They use RR, relative risk, and sometimes they use odd risk. So how do we determine which can be used? Now let's define what is OR. Let's define what is RR. Okay, relative risk is the risk of the exposed group. I mean, how many of those who had the cervical CA and they are smoking? In smoking group, how many of them develop cervical CA and how many of them does not have the disease? And then you look, relative risk is you look in the non-smoker group, how many of them develop cervical CA? How many of them does not develop cervical CA? In other words, if we plot the confusion table, I hope you see that there is 2 kind of table. Here is the exposure and the disease table. The previous specificity, sensitivity, positive predictive value, negative predictive value is talk about the treatment. But here we talk about the exposure. So let's talk about, for example, smoking, non-smoker, and we have the disease CA. This one, no disease, no cervical CA. So we give A, B, C, D. So relative risk is equal to how many of those who is smoking develop the disease, so A plus B, divide by the relative risk, which is how many of the non-smoker who had the disease who had the cervical CA and without cervical CA. So you get the relative risk. In other words, this tells you about the incidence. Incidence, if we define it, it's a new case divided by the population at risk. So for example, in 2012, the incidence of cervical CA in Malaysia populations among the smokers is only 30%. But in 2020, the incidence, the new case, among the populations at risk, among the patient who is smokes, is increased to 70%. So incidence, basically, the new case number. But the odd risk, if you calculate, it's A divided by B divided by C divided by D. So it's not difficult, A, B, C, D. In other words, A times D divided by B times C. Okay. So what is odd risk? Odd risk, basically, it tells you the prevalence. Why prevalence? Because you want to see as a whole. So basically, from the case control, so the prevalence is basically the odds of the case who was exposed divided by the odds of the control who was exposed. So how many of them who is actually smokes develop, the odds of the one who smokes develop the cervical CA, and the odds of the non-smoker who will develop cervical CA. And this is prevalence. That is why in this table, basically, if you do a case control, for you to plot the forest plot, you can only use the prevalence, the OR, because you don't know about the new disease. But here, you know about the new disease. So you can use the relative risk and also OR, either or you can use. At the same time, the same thing here, you can use relative risk and also the odds ratio. So I hope it makes some sense. And for you to go for exam, you just think about this. Thank you.